nutritional support for HIV lecture. You're going to hear a little bit similar things in that, especially relating to the GI tract and mitochondrial support. And it relates to so many conditions, especially with chronic pain and the condition that I'm going to be talking about in this lecture. I titled it, in a case of misdiagnosis, how can we as naturopathic physicians, what could we have done differently? And as I go through the case, as I go through the lecture, I want you to think about what systems are involved with this patient, whether that's immunologic, the nervous system, the GI tract, the gut-brain connection, the gut-joint connection, and then also with the medications that were utilized. How are they affecting this patient and those systems? How do those systems relate to the patient's symptoms? And can this patient's condition be managed with natural therapies alone? Is that possible? Because it does involve severe chronic pain. I want to start off with talking about the epidemic we have with opioid abuse and painkillers. It starts with chronic pain, whether that's an injury, whether that's a chronic inflammatory condition, whether that's an autoimmune condition. Chronic pain is very abundant, and we were just talking about it a little while ago. Somebody might have a very simple injury, and they might be prescribed painkillers for 3 weeks. The problem is that most people do not take opioid painkillers on a short-term basis. They're usually taken long-term, and this is very problematic with all the side effects, especially addiction. So the death toll from opioid abuse is enormous. In 2012 here, it was the almost 40% of over 40,000 American deaths from drug overdoses were from opioids. The problem is these opioids, like I was just talking about, they're usually not taken short-term. They're usually taken long-term. And the other problem is they're usually prescribed in combination with other medications. The problem with that is they're not studied in combination with other medications. They're usually studied just by themselves, just that opioid painkiller. So they were designed to take short-term. They're not. They're usually taken long-term. And a lot of times there is the polypharmacy. This opioid painkiller is usually taken with other medications. We don't know what those interactions are. And those other medications, they have their severe side effects as well. The DEA, the Drug Enforcement Agency, did take your opioid painkiller, especially hydrocodone, from Schedule 3 to your more restrictive Schedule 2. And Andrew Kolodny, right here, MD, President of Physicians for Responsible Opioid Prescribing, he said in quotes, I put in quotes right there, opioids are very lousy drugs for chronic pain. So the question is, what can we have as an alternative to these opioid painkillers? And that's something that we really focus on as naturopathic physicians. Can we utilize natural medicine for chronic pain, especially extreme chronic pain, and the condition that I'm going to talk about? So opioid complications, side effects, we get dizziness, we get nausea, vomiting, constipation, respiratory depression, delayed gastric emptying, immunologic and hormonal dysfunction. And think, when we're talking about immunologic dysfunction, think about your GAL, your gut-associated lymphoid tissue. When you think about the hormonal dysfunction, think about your enteroendocrine cells in the GI tract. Very prominent source of our hormones, especially GABA and serotonin. And as I go through, like I said, think about the systems that are involved with this patient relating to the symptoms. Okay, where does the hormonal dysfunction come in? Those enteroendocrine cells secreting GABA. What do we need GABA for? We know it's an inhibitory neurotransmitter. Think about serotonin and think of the symptoms that this patient is manifesting. And then hyperalgesia, which is actually an increased sensitivity to pain. Well, we're trying to relieve pain with the opioid painkillers. The last thing we want is an increased sensitivity to pain, but that can't happen on long-term opioid use, which, like we talked about, that is usually what happens, is somebody is usually on these opioid painkillers for long-term. And then addiction. The worst is addiction. And I'll talk about the case with this patient. They did become addicted to the opioid painkillers. Not only do we have the addiction, though, we have the withdrawals once an individual tries to get off of these opioid painkillers. And the withdrawals can be very, very severe. Yeah?
Is the mechanism of the hormonal dysfunction of not making sufficient amounts of GABA and serotonin related to the delayed gastric emptying, related to constipation?
Oh, it could be, because I'll talk about too, we have CCK is involved too, cholecystokinin. We know that controls bile release from the gallbladder and also digestive enzymes from the pancreas. So yeah, they can definitely relate it. So NSAIDs right here, mechanism of action. As we know, they inhibit the COX-1 and COX-2 enzymes. That's why we get our side effects, reducing the prostaglandins. The question is, the prostaglandin reduction, that does reduce pain. That does reduce inflammation. The problem is we need those prostaglandins to coat our stomach, to coat our small intestine. That's why you see the ulcers. That's why you see the small intestine bleeding. So they came up with just the COX-2 inhibitors so we can spare the prostaglandins. The problem is when you just inhibit one pathway, everything's shoved down the other pathway. What we started seeing, like with Vioxx, is with the COX-2 inhibitors, is when everything was shoved down the one pathway, what did we start getting? We started getting platelet aggregation and vasoconstriction. People started dropping dead of heart attacks. That was the problem there. So we have a lot of side effects with our NSAIDs, the COX-1 and COX-2 inhibitors. Not only the gastric side effects, the ulcers, the gastric bleeding, but also the cardiovascular effects as well. And that's what this talks about right here, NSAIDs and cardiovascular disease. And this article talked about right here is we've seen an increase in reactive oxygen species. And remember in the other lecture that I gave, I talked a lot about mitochondrial dysfunction. And that's also implicated here with these NSAIDs and the side effects of these medications as we see uncoupling of oxidative phosphorylation. So there is mitochondrial dysfunction. We're not getting the ATP production like we should. So we see things like fatigue. But mitochondrial dysfunction itself leads to chronic inflammation. And that is what we are trying to prevent in this case, is chronic inflammation and the pain. But you can see a lot of these medications that are used to treat chronic inflammation, they cause chronic inflammation. And again, that's why we need other alternatives for treatment. Right here in quotes, the systemic adverse consequences caused by NSAIDs, such as acute myocardial infarction, stroke, renal cancer, gastrointestinal bleeding, are well known. This isn't a secret, it's in the research. It is very well known, the side effects of NSAIDs and the damage they can cause. I want to start with a case. We went over there about the epidemic of chronic painkiller abuse. The other problem with that, though, I want to put in there, is not only are people being addicted to these opioid painkillers, the problem is this leading to the heroin epidemic that we're seeing as well. Because they get a tolerance to these opioid painkillers, they need to move to something stronger, but it's also readily available and becoming cheaper and cheaper as well. And that's the problem with we're seeing with the heroin overdoses. So with the case, we start with a 20-year-old male. Started with, and I want you to think, okay, what is my differential right off the bat? Okay, what is going on with this patient? So we start with right-sided low back pain that radiates to the right gluteal crease. The pain is definitely increased upon walking. With every step, the pain would start here, radiate right here. It would not go all the way down to the foot. It would stop right at the gluteal crease. So think, it had an insidious onset, so it wasn't from an injury. It didn't happen very quickly. It was very insidious. Patient just all of a sudden one day had pain, low back. Stopped right here. So get a differential in your mind already. What are the things, and I didn't give you a lot of information yet, but just try to think, because it's very, very important, because this patient did see a specialist, was diagnosed, had a diagnosis for over 10 years, but it was the wrong diagnosis. And hopefully that's going to be clear to you right off the bat. The pain in the low back was dull and achy, so we did have a sharp shooting pain. But in addition to that, there was dull, achy pain in the low back. It was about a 9 out of 10. Walking, standing, pressure on the SI joint, all increased the pain. The patient went to see a sports medicine specialist. They took an x-ray of the SI joint. It did show degeneration on the right SI joint. Patient was referred to a rheumatologist. The rheumatologist immediately put the patient on non-steroidal anti-inflammatory drugs. They did help in the beginning. So just 2, 1 in the morning, 1 at night with meals. Pain was reduced, inflammation was reduced, mobility was improved. The problem is after about 3 or 4 months, the medication didn't have the effect anymore, the pain came back. This went back and forth for about 6 months, and then in addition to the NSAIDs, painkillers were added on top of that, specifically Vicodin for this patient. Just one Vicodin, and then it was moved up to 3 NSAIDs a day. So think about what these medications are doing to the body. What did we just talk about? What effect are the NSAIDs having on the GI tract, on the cardiovascular system? And again, if we're talking about the GI tract, we can't separate it from the immune system and from the nervous system. So think about everything that's at play here and all the symptoms that this patient started expressing. Rheumatologists diagnosed the patient with sacroiliitis. That was clear. But the patient was also diagnosed with rheumatoid arthritis. So already think in your mind, what is the criteria for the diagnosis of rheumatoid arthritis? What do we need? Yeah, so give me some of the things. What would they manifest physically? What we have for rheumatoid arthritis? Nodules, yeah, I heard nodules. What else? Yeah, she's got it. In the periphery, I heard you say the swan neck too, but the hands, the feet. So the ankles, the feet, the wrists, the hands, especially the pivot joints, proximal interphalangeal joints of the hand, usually not the distal, but usually the proximal. Extremity involvement, how about rheumatoid factor, anti-CCP? Those were not run. So here it is, American College of Rheumatology. Here's the criteria for the diagnosis of rheumatoid arthritis. You guys named some of those. Morning stiffness in and around the joints for at least 1 hour. That was the only one that this patient presented with. Swelling or fluid around 3 or more joints simultaneously, that was not there. At least one swollen area in the wrist, hand, or finger joints, as you alluded to, that was not present. Arthritis involving the same joint in both sides of the body, whether that's the fingers, the wrists, the ankles, could be the knees, could be the elbows. That was not present. You mentioned rheumatoid nodules. Those were not present. Abnormal amounts of rheumatoid factor in the blood was not tested for. X-ray changes in the hands and wrists, typical of rheumatoid arthritis. X-rays were not taken. Rheumatoid arthritis is officially diagnosed if 4 of the 7 factors are present. This individual had 1 of them, but was still given the diagnosis of rheumatoid arthritis. We talked about the medications, eventually got up to 3 NSAIDs, 4 Vicodin a day, switched brands and dosages of the NSAIDs around 10 to 15 different times. They were switched so many times that this individual didn't even remember the names of the medications. Oral high-dose steroids were given 4 to 5 times a year. Now think about, what do corticosteroids do to the body? Any thoughts? What do they affect? They suppress the immune system. They break down. They can affect the bone. What else do they affect? What do we see? The rupture of collagen structures like the tendons. Yeah. Absolutely. So think about that, especially the tendons that are affected with corticosteroids and what this patient presented with. It's going to be very, very important. So labs were run. Went to a PCP, CBC, CMP, Lyme's disease, all were negative. The thing is, this was after about 6 years. So from age 20, remember this is when this started. 6 years later on these medications, 3 NSAIDs, 4 painkillers, periodically 4 to 5 doses of high-dose corticosteroids orally. That was to take down the inflammation, to try to get it to the point where the NSAIDs and the painkillers would work. We know how powerful those are, immunosuppressants. After 6 years of all of these treatments, the patient started to manifest with extreme headaches, extreme anxiety attacks, extreme fatigue. So in addition to that, heart palpitations, which a lot of times can go with anxiety attacks. Somebody, they literally think they're dying, they can't breathe, they think they're going to have a heart attack. That's why the patient was eventually diagnosed with anxiety attacks, but EKG was ran, chest x-ray was ran, all negative, MRI in the brain because of the extreme headaches, MRI, EEG, all negative, again diagnosed with anxiety attacks, prescribed anti-anxiety medications. Now put those anti-anxiety medications on top of the NSAIDs, corticosteroids, and the painkillers. In addition to their condition, think of the impact these medications are having on the systems and the symptoms. Are the symptoms just from the condition itself, this chronic inflammation, or can it be from the medications themselves? Ativan was prescribed as needed, in addition to 2 or 3 other anti-anxiety medications. The patient eventually got off of these a year later because they were just completely sedated all the time in a brain fog, couldn't even think straight. Did keep the Ativan, though. They did carry that around with them because the anxiety attacks were so severe. That was helpful just to have the Ativan on hand because that will calm somebody down immediately. So it was comforting just having them. So the turning point came after 7 years. So remember, from age 20, now at age 27, the patient goes back to the rheumatologist on all the medications, still experiencing all of these symptoms, even worse than before, everything we just went through. And the rheumatologist says, there's no more that I can do for you. I can't put you on a higher dose of a medication because you're way too young. Think of the effect that it's going to have on the liver, especially the things containing the acetaminophen. Vicodin is hydrocodone and acetaminophen. A lot of the other painkillers and drugs that were taken contained acetaminophen. So he did not want to put on a higher dose, fearing that it would destroy the patient's liver. So this was a turning point where the individual really didn't have any other choice. There was no one the rheumatologist referred them to, saying, here's another way, here's another option, here's something else that you can do. Since I can't help you, there's no more I can do. The patient was just on their own. So it was keep taking the medications and be out of some sort of pain, but eventually die from the complications of those medications, which the rheumatologist did state, you're way too young, this is going to shorten your lifespan, or live in chronic pain and stop taking the medications. Well, fortunately, this individual did not just settle for either one of those. They did research natural therapies, diet, anti-inflammatory foods, anti-inflammatory supplements that we know are very, very powerful. Yes, you can use food as medicine. There are very powerful anti-inflammatory natural supplementation and exercise, especially for this individual. Exercise and specific exercises were very, very important for their condition. I hope, again, you're thinking through a differential already of what this could be. So after implementing these therapies, these anti-inflammatory foods, these supplements, start to implement exercise, this individual weaned themselves off their medications after about a year and a half. As a physician, I tell individuals all the time when I talk about this case, you don't want to do that. We know we don't want people taking themselves off medications on their own. It should be with a physician very safely. But this patient had no other options. They were given no other choices. So the average pain after getting off all the medications was still a 6 to a 9 out of 10, and flare-ups were still happening twice weekly. And when these flare-ups would happen, this individual could barely get out of bed. They could barely walk. They would just take one step at a time. This is about as fast as they could walk when there was a flare-up. Average pain right there, but 10 out of 10 when there was a flare-up twice weekly, taken over-the-counter pain relievers, NSAIDs, about 6 to 8 when the flare-ups would happen. But they were on no prescription medication. So this was a success for them, that they were managing their condition with natural therapies or just over-the-counter medications. So after about 1 to 2 years of natural therapies, the pain level drops to about a 4 to a 7 out of 10. When we were at a 6 to a 9, you can start seeing this is cumulative, but it does take time. It took a lot longer for this individual because they didn't have the right diagnosis. It would have helped, and they would have known how to specifically treat their condition, even naturally, if they would have had the right diagnosis. It was very, very key for this condition, and we'll talk about why. So the pain goes to a 4 to a 7 out of 10. The flare-ups now, instead of twice a week, are now twice a month. So this is progress. We're seeing progress take place. Still taken over the counter, various pain relievers, NSAIDs, sometimes Excedrin, 6 to 8 Excedrin, which is a combination of acetaminophen and aspirin. So again, it's still having that acetaminophen effect on the liver. 6 to 8 of them during the flare-ups, just to walk and sleep at night. And now think of a condition that causes not only to have the pain and stiffness in the morning, but at night, very, very deep spinal pain that wakes them up at night. And of course, at the top of your list should be, okay, cancer. Is cancer part of that? Wakes you up at night, especially deep in the bone. I'll just tell you right off the bat, it's not cancer. Okay, but think of a rheumatological condition that affects the joints, that wakes somebody up with deep, deep spinal pain. And again, during the flare-ups that are happening twice a month, again, taking the over-the-counters, but there was occasional blood in the stool, and we know why. This is damaging the GI tract, we can see. The therapies, the natural therapies, did have such a life-changing effect on this patient, though, that they did start to research other forms of medicine. They were a teacher at the time. But because of this transformation, they did want to go into medicine. They did want to help individuals in medicine, but they didn't want pharmaceuticals to be the only option. They wanted another way. They didn't know there was. Never even heard of a naturopathic physician. Started to research, came across it like, wow, this is great. This is wonderful. I can help people, and I can change their life. But my only tool doesn't have to be prescription medications. I have other tools. Become a naturopathic medical student, and it was during that time, in about their third year, that they were talking to one of the interns in one of their classes. And they were telling them about their diagnosis, about the rheumatoid arthritis and everything that's going on. And what you alluded to, it's like, well, do you have any pain in your wrists, in your hands, in your ankles, your feet? And this was the first time. This is, what, over 10 years later. And the student never questioned the diagnosis, never looked into it. They just assumed I got a diagnosis from a specialist, rheumatoid arthritis, that's what I have. They never thought it's not my hands, my ankles, my elbows, my knees, it's just in my back. But the intern said, you know, you might want to look into ankylosing spondylitis. This sounds like what's going on, and this person has never heard of that diagnosis before in their life, never heard of it. Start to research it, and looking into the criteria for AS, which is very hard to diagnose. But they start reading ankylosing spondylitis most often affects white males between 15 and 40 years of age. They fell right in with that criteria. The inflammatory back pain has an insidious onset, which we talked about, has a dull quality. Yes, they did have the shooting sharp pain in their SI joint down to the gluteal crease. But for the most part, it was a dull quality. It just happened to be a 10 out of 10 dull quality. Pain radiates in the gluteal region, yes, and eventually it went to both sides, both SI joints, it went down to both the gluteal crease on the right and left side. Back pain was definitely worse in the morning and definitely improved with activity with this individual. The more they walked, the more they exercised. It'd be painful in the beginning, but after a while, the pain would be relieved. Did have a nocturnal component, which we talked about, would wake up with that deep pain in the hips and in the spine. And there was extreme fatigue with it. So everything lined up exactly 100%. More difficulty breathing with reduced chest expansion. We know that AS affects the axial skeleton. So whether that's the hips, the entire spine, the ribs, and the sternum. So a lot of times somebody with AS, because it is affecting that costocartilage, the inflammation there, whether it's the sternum, the ribs themselves, they really get that decreased chest expansion with their breathing. Associated with subclinical gut inflammation, and this is what we're really going to hone in on here because this is so key to helping this patient get better. And they did. They had digestive problems their entire life. It never made the connection between the gut and their joints. That was never brought to their attention. It was just focused on the level of the joint. Most commonly in the axial skeleton, talked about that. Sacroiliitis on plain radiograph with increased joint space and sclerosis. That was actually the first thing that was taken actually by the sports medicine specialist were the x-rays and the changes in the SI joint, if you remember back to the beginning. Patient fit symptom picture, 100%. Even on physical exam, there was restriction in the cervical, thoracic, lumbar spine, flexion, extension, rotation. There was pain. I mean, just in physical exam, going down the spinous processes, starting in the cervical, thoracic, lumbar, all the way to the SI joints, very, very light palpation caused pain with this patient. They would jump even with the lightest palpation on the spinous processes, which is very indicative and common with AS. Labs were run, blood tests for HLA-B27. They were positive. You do not have to be HLA-B27 positive to have AS. It's just most people, if they have AS, they are HLA-B27 positive, but it's not a prerequisite to have it. Rheumatoid factor and anti-CCP, which are used to diagnose rheumatoid arthritis, those are both negative. Imaging, x-ray, cervical, thoracic, lumbar, and SI joints, the results, slight degeneration and osteophytes in the cervical spine, there are osteophytes in the lumbar spine, and the SI joints on the right side, remember that's where the pain started. So it's definitely there the longest. There was definitely severe degeneration in the right SI joint and just slight degeneration eventually in the left SI joint itself. If you looked at x-rays or even an MRI of this patient's spine, it would be totally trashed. 31-year-old male, diagnosis is eventually correct in ankylosing spondylitis. We will talk about why that is so key in this patient making progress. This patient does further research and finds out the connection between subclinical gut inflammation and AS. You don't have to have overt inflammatory bowel disease to develop these, whether it's any rheumatic condition or AS itself. You don't have to have, again, Crohn's disease, ulcerative colitis. There can be subclinical. Subclinical gut inflammation, meaning you might not have any digestive symptoms at all, but there's still inflammation going on in the GI tract. It's triggering this whole process that we're going to talk about. Research is the link between microbial pathogens, especially Klebsiella. There has been research done on Klebsiella, gut inflammation, especially related to AS, and we'll talk about the molecular mimicry that's involved there. It doesn't have to be Klebsiella, though. It can be other pathogenic microbes. In the research, though, they have seen that starches specifically enhance the growth of Klebsiella. We know that these sugars and starches enhance the growth of most pathogenic bacteria. So this patient eliminates sugar, starches, and dairy, so the symptoms of pain improve even more. Flare-ups, remember, they were every 2 weeks, and then they were every 2 months, and now they're once a year. So again, with the correct diagnosis, with the research, we can get more specific. Okay, Klebsiella gut inflammation is linked to this joint pain. What's the fuel? Again, it's like we do. We trace everything back. What is the cause? What's going on? What's the process here? So if starches, sugars, if they're feeding this, they're feeding the Klebsiella that's initiating this inflammation, attacking the joints, it would make sense to take away their fuel. We're going to see a lot of progress, and we did. Flare-ups again once a year. Now the pain's going down to a 3 to a 5 out of a 10. 6 to a 9, 4 to a 7, now 3 to a 5. So what could have been done differently? I have the slide up here, but any advice of what could have been done differently right from the beginning? Review of systems, looking at the GI tract, going back to this patient's history. Did you have any digestive symptoms? And yes, they did. From 10 to 31 years old, the patient had persistent digestive issues, alternating constipation, diarrhea, bloating, indigestion. That's 21 years. That's a long time to have damage done to the GI tract. The question is why. Even those years, fatigue, lack of mental clarity, difficulty concentrating, and lack of coordination. Again, think of the GI tract, think of the immune system, think of the nervous system, the connection with the vagus nerve. Even these inflammatory cytokines getting into the bloodstream, crossing the blood-brain barrier, especially in the hypothalamus where it's leaky. Think of what our hypothalamus does. And of course, the diet, starting at 10 years old, is very high in processed sugars, starches, and dairy, pasteurized dairy, of course. So autoimmunity and rheumatic diseases is induced by microbial infections via cross-reactivity or molecular mimicry. I got to read it here. I usually like to talk and I like to read from the slides, but a great amount of data supports the notion that AS is caused by subclinical bowel infections with Klebsiella microbes. To show you I'm not making this up, this is in the medical literature. Over and over and over again, you'll read about subclinical gut inflammation, gut permeability, cross-reactivity, molecular mimicry. Talking about it right there. Molecular mimicry, production of antibacterial and cross-reactive autoantibodies, the propagation of this disease, not only initiation, but the propagation for it to continue. Go to this slide right here. This is talking about the cross-reactivity with rheumatoid arthritis and ankylosing spondylitis. Proteus is one of the bacteria that has been found to be initiating in rheumatoid arthritis, the Klebsiella with the ankylosing spondylitis. But what we have right here is the molecular sequence, the amino acid sequence of the ureases, which is an enzyme produced by Proteus. And what it's showing there is the mucosal immune system, again, the mucosal, the gut, gut-associated lymphoid tissue, is stimulated by the antigens from these enzymes on the Proteus. And what they'll do is, because the molecular sequence there, the amino acid sequence of the urease and collagen type 11, where rheumatoid arthritis is at, in these joints, what will happen is we get the cross-reactivity of these antibodies, again, with the enzyme from Proteus to the collagen type 11. We get that cross-reactivity. But where did it start? And it started at the joint. It started in the GI tract with these microbial pathogens. And with Klebsiella, it's the same thing. The nitrogenases, fulminases, these enzymes produced by Klebsiella, our immune system It attacks it, recognizes a molecular sequence, but that molecular sequence is very, very similar, almost identical, if you can read the letters from there, to what? HLA-B27, but also collagens type 1, 3, and 4. More evidence of the gut inflammation, where these microbial pathogens are starting. And what this is a sequence just talking about the introduction of a low-starch diet and the pathophysiology leading to AS. It's what we just went through right there. More research from that same article talking about these antibodies in Klebsiella being produced in the enteric mucosal lymphatic system, extra-articular regions, meaning outside of the joint in the gut. Gut inflammation, and right there at the bottom, gut flora plays an important role in the pathogenesis of B27-associated arthropathies, gut flora. World Journal of Gastroenterology, we hear a lot when it comes to chronic inflammatory diseases, different autoimmune diseases, but especially AS. I actually lead a support group, a spondylitis support group through the Spondylitis Association of America. And a lot of the people who will come to that support group, they'll be on your TNF-alpha inhibitors, your Humira, your Enbrel, you name it. Because they have found that TNF-alpha, there's other ones in the newer research, it's not the only cytokine, it's just one of them that they've identified. But they'll be on the TNF-alpha inhibitors. And what this article talking about right here is that TNF-alpha, yes, it is implicated in the inflammatory process. But what it talks about is where is this TNF-alpha being produced? And I'll educate the individuals that come to that group. Yes, you're blocking TNF-alpha. But if we go back to the cause, where is this TNF-alpha coming from? And it talks about right there, the antigen-presenting cells, especially like macrophages, they're being introduced to something. Whether that's pathogenic bacteria, whether that is undigested food particles, from gut permeability, something is triggering this antigen-presenting cell to release TNF-alpha, to stimulate your T cells, that will stimulate B cells, that will create plasma cells. But this is happening at the level of the gut, and this is from the World Journal of Gastroenterology. This is not from Naturopathic Medicine Journal. Okay, this is the medical literature. This is the research. But the medical literature has got to be reviewed. I have found out in educating individuals and speaking even my support group, that there's a disconnect between what people are being told and then what is in the medical literature out there. And if you do review the medical literature, they talk over and over and over again about the gut microbiome and about gut permeability. It is there. And it's talking about it, this molecular mimicry, and where this TNF-alpha with all these other inflammatory cytokines are being produced. And it talks about right there, the clinical observation, initiation and perpetuation of the altered immune response that leads to joint and enthesis inflammation. And that's what's being attacked in ankylosing spondylitis and all those different sites of the body, is at the entheses, where your tendons and ligaments insert in the bone. And at the bottom there, I don't know if you can see it, but it said these discoveries have had important therapeutic implications. Yeah, you better believe it has, because if we alter the gut microbiome, and we can stop this inflammation from ever starting in the first place, you know, that is going to give us amazing clinical outcomes with patients without the significant side effects. Here it talks about the injection of corticosteroids. This patient was on oral corticosteroids. This talks about the injections, but non-steroidal anti-inflammatory drugs. Well, the mainstay of the treatment for these patients we talked about are corticosteroids, NSAIDs, and the painkillers. The problem is a lot of these treatments, they damage what? They damage the intestinal tract. That's the problem to begin with. And that's what I try educating individuals on, especially with this condition, but it's something new to them. It's just to wrap their head around it that their gut and the gut bacteria, they've never even heard the term gut bacteria, which is pretty frustrating to me. They're not educated that that's where this is all beginning, but here's the research right here. And then the drugs that they're given are damaging where this inflammation is starting from in the first place. So again, we've got to target the GI tract, we've got to target the gut microbiota, got to heal, again, that gut lining if we want to stop this inflammation from beginning. And again, studies have shown that up to 70% of patients with spondyloarthritis have inflammatory intestinal lesions. Treatment of rheumatic manifestations of inflammatory bowel disease yeah, most patients do respond to NSAIDs to control the symptoms, as it says right there. But again, it doesn't stop the joint destruction. And again, it can exacerbate the problem because, again, we're affecting the GI tract, especially those tight junctions, that leads to that gut permeability. And it talks about here the use of probiotics in treatments of patients with AS. It's nice to find in medical literature that it is there talking about probiotics and modulating that gut bacteria to help the gut wall, to reduce that inflammation, talk about how it has an anti-inflammatory effect. This is just about patients at an AS clinic in London, how they introduced diet, took away the starch for the Klebsiella, and that patients were treated with the dietary therapies alone, without pharmaceutical treatments. So again, what else could have been done different? What we went through right there is, well, we could have looked at the review of systems of all the GI problems with this patient. And then what I did is I showed you all the research to say why that was so important. The patient had these digestive problems from 10 to 31 years old. Why was that so important? Well, there's research saying why it was so important. If they would have been looked at the level of the gut and been treated there, we could have stopped this inflammation at its source. Also, if we look at a review of systems, neurologically from 10 to 18 years old, there was a lot of motor and vocal tics. The vocal tics worse around 10 years old. The motor tics more around 18 years old. Again, think of what's at interplay here with our gut-brain connection, with the vagus nerve. These inflammatory cytokines, again, being released into the bloodstream and crossing the blood-brain barrier. This talks about right here, the link. So we talk about the review of systems with the GI tract and then the research backing that up. Now this is talking about the neurological manifestations that this patient experienced. Now the research talking about GI diseases and neurological conditions like depression, anxiety. And right there, in up to 80% of patients, there was an alteration of microbiota that can affect central nervous system function. Talks about the modification of the microbiota with probiotics, reducing anxiety, and even cortisol levels. And we talked about GABA. We talked about those enteroendocrine cells producing GABA, talking there about probiotics impacting GABA production, which we know that has a lot to do with behavior. If there's any kind of a tic, or we can even talk things about like ADHD, where there's a lot of movement, there could be a deficiency in GABA, and we have an overabundance of like glutamate or excitatory neurotransmitters. And talks about bifidobacteria affecting serotonin. Again, what's produced in the GI tract, over 90% of it is our serotonin for those enteroendocrine cells. And it's talking about how the microbiota is affecting that. The emotion, again, the vagal nerve, differentiation of Th17 and T regulatory cells, and again, the immune system and the blood-brain barrier. Here it just talks about those enteroendocrine cells I was talking about secreting the gut hormones. Not only the serotonin, not only the GABA, but what you were talking about with the CCK, which we know affects digestion, the secretion of bile from the gallbladder, even stimulating the pancreas to secrete digestive enzymes, which in this patient was a big deal because digestive enzymes were very, very important for the change in their health. Talks about the gut permeability. I talked last time about mitochondrial dysfunction. Again, I put it here because mitochondrial dysfunction is absolutely essential anytime we're talking about the immune system, because we have mitochondrial dysfunction, we're going to have the chronic inflammation. And this research article I'll talk about right here, the many roads of mitochondrial dysfunction in neuroimmune and neuropsychiatric disorders. So again, don't forget, we do have the GI tract, we do have the gut microbiota, but we do got to support that mitochondria. So the patient's current lifestyle and health status for the last 10 years, the patient has been on no prescription medications. The least amount of pain they've ever been in 18 years, it fluctuates between a 0 to a 10 out of pain, with 10 being the worst pain. And again, think about how was this possible? And that's why I took you through, if you would have looked at the review of systems and what was going on with this patient, if the history would have been looked at further, and other therapeutic interventions would have been introduced to modify that gut bacteria to help with that chronic inflammation, we could have shut it down at the source. And then also mitochondrial support. And that's what this patient, that's what they did. They had the GI support, whether that was enzymes for helping digest the food, probiotics to modify that gut bacteria, taking away the fuel for the pathogenic bacteria, the sugars, the starches. Inflammation started to dramatically decrease. So you can see that is possible, and that's what this patient eventually did. They were able to treat it with natural therapies alone because they got to what was causing the chronic inflammation in the first place. Nutritional supplementation, again, talked about the digestive support, anti-inflammatory supplementation, and again, our mitochondrial support. Again, the patient's current lifestyle and health status. It was so important that they found out the diagnosis was ankylosing spondylitis because posture is so essential with AS. You got to have correct posture all the time and movement. So when this patient found out that I do have AS, I need to be moving all the time. I need to have correct posture, whether I'm sitting, whether I'm walking, whether I'm standing. They found out how crucial that was, and that took them to a whole nother level. So we talked about everything they did internally at the level of the GI tract, supporting their mitochondria, but then also when they started to find out, okay, what do I need to strengthen? Started implementing exercises to strengthen what's called the posterior chain muscles in their back, especially the hamstrings, the glutes, and their entire paraspinal muscles. It took them to a whole nother level because we know what does AS want to do. If you've ever seen a picture of it, it wants to take the body like this. We've got to strengthen all of this to bring the body into that. We've got to fight back against that AS of what it's trying to push the body into. The problem is when AS forces the body into this posture, that causes what? Causes more breakdown, more degeneration in those spinal joints, throwing everything off, all the way from the cervical spine, all the way to the SI joints. And then again, affecting the ribs, affecting the sternum, affecting the hips. So once those muscles can be strengthened, and proper posture can be developed, the pain can be reduced dramatically because we're slowing down that degeneration, we're slowing down that inflammation. They also incorporated deep breathing, and I just have right here why that's so essential, because we know that deep breathing can activate the parasympathetic nervous system. That has an anti-inflammatory effect through the vagus nerve. And also right there in the picture at the bottom, inhibiting, reducing levels of TNF-alpha. And we know how powerful that is in the pathogenesis of this condition. A lot of people do say when I talk about this case that it's too extreme. You know, that dietary protocol, being on that supplementation, having to have essential posture all the time. They say there's just no way, you know, that's worth it. That's just too extreme for me to have that kind of a lifestyle. For this person to have that kind of a lifestyle. It's not that extreme. And I know that it's not because that's my case. I took you guys through my case, my journey through these whole years. It started actually when I was younger, probably around 10. I actually had pain, I can remember, in my Achilles tendon, the bottom of my heel,